Good afternoon, postgraduates and students from across our country. I'm Dr. Rajasekaran, Chairman of the Department of Orthopedics and Spine Surgery, Ganga Hospital, and also the past President of Indian Orthopedic Association. I have with me my colleague, Senior Spine Consultant, Dr. Ajay Prasad Shetty from Ganga Hospital, also to be the co-faculty over here. And I'm so glad that all of you are here to participate in the second webinar of the PACE PG Academy for Continuous Excellence 2020, which is conducted by the Indian Orthopedic Association in collaboration with the Janssen India and Insignia Learning. I'm sure that this is a good endeavor which will help you to connect to the best of the faculty from all over the country, from in fact across the world too, because I think the OTA USA also is going to be a part of the future webinars. So today we will be talking about a very, very important topic, that is spinal infections. And you know that TB spine is now a big problem, although it is a disease of as old as man himself. Now, the greatest and the ongoing war in history was not between two countries or two civilizations, but it is the war between man and germs. And the time that we are living now, the present day, is also a witness to this statement. More men have fallen to the power of the germs than any other force or evil in history. And it often has been a very unequal fight. Tuberculosis, pyogenic infections, granulomatous, cystic, fungal, and postoperative infections have killed more people than any war in this world. And TB has been a master of these infections from age to day. It has actually ruled over the destiny of men through centuries. And it does not spare the royalty, it does not spare the elite. It has killed many people in the royalty. It has even killed Nobel laureates. It has killed Napoleon II, Louis XVII of France, Louis Braille, John Keats, King Henry. So many, many important people and famous people across the world have fallen to this. And that's why it's called the captain of all these men of death. Now, for many centuries, there was no good treatment at all. And there was only the sanatorium treatment with sunshine, rest, nutrition, hope, and prayers, the only form of solace. And often the treatment was not very successful, and it was sometimes more unkind than the disease itself. And there were some initial attempts for surgery to remove and debride the focus, but often the results were disastrous. That's why Calais in 1930 said, "The surgeon who, so far as tuberculosis is concerned, swears to remove the evil from the very root, will only find one result awaiting him, the death of the patient." So till the chemotherapy was possible, till we had drugs which was very effective in controlling the disease, surgery was a big disaster. And we had the first drug, isoniazid, and then came the streptomycin, the rifampicin, ethambutol, and pyrazinamide. And these actually gave us the winning sword. And over a period of time, uncomplicated spinal tuberculosis became so much easily treatable by medicines that it was transformed into a medical disease. Now, when I use the word uncomplicated spinal tuberculosis, I mean a spinal tuberculosis which does not have a neurological deficit or something where there is a big collapse and a deformity. Now, this was very well proved by the MRC trials which were conducted all around the world. And if you're a postgraduate, this is often an exam question, and you also need to be very well aware of this. Of these trials which were conducted very well in Korea and in Madras and in Hong Kong. And in effect, they all proved that conservative therapy with oral anti-tuberculous drugs was as good as radical surgery. Because with conservative therapy, you can see here, bone lesions healed very well as in this case. And even if you have very large abscess, as you can see over here, a very large retropharyngeal abscess. Fortunately, in this child, there was no respiratory symptoms. There was no need for surgery. And you can see by chemotherapy, there has been a complete resolution of these abscess. Now, even more dramatic cases like this, you can see this is a patient of Dr. Shekhar Bojraj, a very alarming lesion in the upper cervical spine. Large epidural abscess, a big compression on the spinal cord, but you can see that it has very well completely cured with an excellent result. So the first learning point is that uncomplicated spinal tuberculosis in the present age is still a medical disease. And this was clearly shown by the last of the MRC trials, which was conducted in Chennai, Madras, which was called the Madras Study of the Tuberculosis of the Spine, which at 10-year follow-up, you can see that ambulatory chemotherapy achieved a favorable status equally as radical surgery. Now, this was a very good learning, but there was only one problem with that. The MRC trials did not include patients with neurological deficit, and they did not include deformity as a criteria for assessment. So, even though we know that the disease can be completely cured, as you can see here, there is an unfavorable natural history. This patient has been cured of spinal tuberculosis, but ends up with a very large deformity like this. And we cannot say that a buckling collapse like this is a successful treatment, because we know that deformity is a very big problem, and depending upon the level of the deformity and the severity of the deformity, the patients can end up with secondary paralysis over a long period of time, or you can have a secondary cardiopulmonary deficit, or when it happens in the lower lumbar spine, it can completely offset your sagittal balance, and it can cause problems in your stature and also give you a lot of pain. Now, what about the cosmetic deformity? And this is very important when it affects young people, either a boy or a girl, it doesn't matter. But when you have a kyphosis, now this is actually a very big problem, and we also have to be cognizant with it. So in the patients who are included in the Madras study of tuberculosis, the first idea that we thought was, is it possible to predict the final deformity in these patients? Because chemotherapy is very good in clearing the disease. So we then need to operate only on patients in whom there is an increase in deformity. And we came out with a formula, but sufficient to say that any patient who had an increase of vertebral loss of more than 1 in the thoracic or the thoracolumbar junction, it was appropriate to operate. So we then went into deeper into what is the problem of deformity in spinal tuberculosis. And we found in the 15-year follow-up of 387 patients that 15% of patients who were treated conservatively ended with a deformity of greater than 60 degrees. But what is the most important observation was most of the results were as a result of childhood spinal tuberculosis. Now, this is because when you have an adult, there is an increase in deformity during the period that the patient is having healing. But you can see here, once there is healing of the spinal tuberculosis, there is a good consolidation and there is no increase in deformity. Whereas the red line shows children. The collapse is a little more during the active phase of the disease. But even after the disease has been completely cured, you find that over the entire period of the growth, there is an increase in deformity, not because of activity of the disease, but because there is a growth modulation which is taking place. A very good example is this. You can see 36 months after the healing of the disease, the deformity is 40 degrees, but at 180 months, the deformity has increased tremendously to 115 degrees. Now, this was very important, and this all of you have to remember that the progression of the deformity in children happens much more after the cure of the disease, and it progresses throughout till the growth is completely over. But all the changes that happen during the growth is not for bad or for worse. As you can see in this patient, at 60 months, you can find that L2 and L3 are collapsed a lot. But at 10 months follow-up, you can see that there is an anterior growth. And at 15-year follow-up, you can find that this consolidation mass has grown tremendously so that the deformity has been completely made okay. Now, another example, here you can see that there is a deformity of 41 degrees, but at 15 years, you can see that the fusion mass has grown anteriorly, what we call as the regional accelerated growth by growth modulation. And the kyphosis of 41 degrees has reduced to 20 degrees. So the learning from this study is actually two. That childhood spinal tuberculosis is in fact two separate diseases. In the acute phase, it is an infectious medical disease. But even after the cure of tuberculosis, this acts like a spinal deformity, which is modulated by the biomechanics of growth, and it can actually show a tremendous increase in deformity. Now, here comes the very important question. So, why do some children improve and some children deteriorate? Now, this was the point that we actually saw and studied in this publication, the natural history of post-tubercular kyphosis in children, where only the children who participated in the Madras study of tuberculosis was actually studied. And to our surprise, we found that there was a lot of variability in observation. 39% of children deteriorated, but very surprisingly, 43% improved and 17% showed no change. Now, the question that comes begging is, why do some children deteriorate and why do some get better? So we went back into the study, and one of the most important things we noticed is that all the children who deteriorated had a dislocation of the facet joints during the active phase of the disease. Now, when we look at a picture like this, very rarely do we actually look at the facet joints. We concentrate quite heavily on the anterior column, but we do not notice what is happening at the facet joints. Now, once the facet joints dislocate, you will find that it leads to many different types of progress, depending upon the status of the facet joint. Now, if the facet joints are intact, you find that there is a wide area of opposition of these vertebral bodies. And then there is a phenomenon of the regional accelerated growth. And these patients have a very good outcome with spontaneous correction of the deformity. If you have one or two facet joints dislocated, there is a point contact over here. And these patients have a suppression of growth at this level, and the deformity is about 60 to 70 degrees. Whereas if you have multiple facet joints dislocated, then you find that there is something called what is called the buckling collapse that happens. And these patients have a huge amount of deformity and collapse. Let's see some clinical examples. So there is a single facet dislocated over here. You can see that there is a point contact over here. and the kyphosis that happens here is approximately about 40 to 60 degrees. When there are more than two facets dislocated, you can see that there is not only an increase in deformity, but even vertebral bodies which are intact and not affected by the disease, they get attrition of the vertebral body because of instability and pressure. And so there is an increase to 71 degrees. But if you have multiple facet joints dislocated, and this happens in children, whenever there are two or three vertebral bodies lost, now you will find that these children have something called a death of the column, because the leftover remnants of these vertebral bodies are pushed behind, and then at 30 degrees of kyphosis starting, you find that all the vertical forces are converted to translational forces, and so there is a complete collapse of this column, and you get a phenomenon called buckling collapse of the spine. Now, what is meant by buckling collapse? In other forms of kyphosis, you have the posterior column intact. But in buckling collapse, you have a complete disruption of the posterior column. And because the TB has already taken away a part of the anterior column, both the columns are completely destroyed. And so there is a complete collapse of the whole spine. And you will find that the entire rest of the spine is converted to two large compensatory curves. Now, this is a phenomenon which happens very frequently in TB spine. And you can see that this is a massive collapse over here, which is a very undesirable outcome. In many of these patients, you find that there is a complete collapse. And you have another phenomenon that when you take a CT scan, you find that there is a problem of two vertebral bodies. You see them completely two transverse sections of the vertebral bodies facing each other with a large bursa in between. Now, this horizontalization has also one more important fact. Now, if you see a vertebral body of the humans, these vertebrae are always shorter and broader. But if you see the vertebral bodies of the quadrupeds, you will always find these vertebrae are much longer. That is because of the absence of the center of gravity forces on the vertebral end plates or the growth plates. Now, when the horizontalization of the vertebra occurs in humans in the buckling collapse, you find the same thing happening here. You can see that these vertebrae become very much longer. And this is the reason why these parabola increases, and then these patients get a secondary late onset neurological deficit. So what is the bedside value of this work? The most important factor to think is that to realize that facet dislocation is a clinical event that indicates a point of no return, after which compression becomes completely detrimental, and there is a massive increase in deformity. So is it possible that we can identify children who are at risk for this massive deformity? And that is why we came out with spine at risk radiological signs. Now there are 4 signs over here. Now the first one is on the lateral view. You can actually see that a facet dislocation has taken place. The second sign is retropulsion. When you draw lines on the posterior part of the body of intact vertebra, you will find that the affected vertebra are retropulsed behind. The third sign is the lateral translation. When you draw a line connecting the pedicles of one segment, you find that there is a lateral translation. And the last sign is called the toppling sign. When a line is drawn on the anterior surface, you find that it cuts on the superior surface of the toppling vertebra. Now, all of these signs actually represent the same, that the facet is dislocated. Now, if the facet is not dislocated, retropulsion cannot take place, lateral translation cannot take place, and the toppling over cannot take place. So when you have these signs, and if you can find these on a child's X-ray, then it means that if you do not intervene at that stage, many years later, because the collapse occurs over a long period of time, and that is the most important thing to know. Now, you will end up in a disaster like this, which you should stop. So what it means is that when you have a child like this is a 4-year-old child, has got a healed tuberculosis. Patient has got no pain and the child is running and there is no neurological deficit, but there is a spinal wrist sign positive. And so what you need to really do is to go and operate and do a spinal stabilization so that a buckling collapse does not limit. Now, the other value that we learned is that the value of the spinal wrist sign was not limited to posterior post-TB kyphosis alone. Now, this is a case of congenital kyphosis. You can see from 33 degrees, it has increased to 104 degrees. And the reason is very obvious over here. You've got a facet dislocation. Another case of congenital kyphosis, you can see that there is fusion. Posteriorly, facets are dislocated. And you can see that there is a massive increase in deformity. Again, in achondroplasia, when you see that the facets are dislocated, these patients will progress quite a lot. So the central learning point is no child with spinal tuberculosis must be discharged from care till growth is over. Because if you see the original publication, you can see the patient is cured of tuberculosis at this stage, but they can either have a massive and continuous increase in deformity, or there can be a very silent period, a plateau stage for some years, and then there can be a massive increase in deformity. So this we have to be very careful. So much for deformity. So what about neurology? And it is very surprising that till date, there is no good randomized clinical trial available in this world to know how to treat a TB patient with neurological deficit. Now, you know that the neurological deficit can be caused acutely or in the late stages. Now, in the acute stage, it is either due to a compression of the cold abscess or a collection of the caseous material, or a retropulsion of the sequestrum and the disc, or instability and translation of the spinal column, which it can happen. Or in any single patient, it can be a combination of all of this actually. In the other variety of neurological deficit in late stages, it is usually because of bony compression and increase in deformity, as you see over in this patient. Now, because there is no randomized or large sample studies on this important structure, we find that there are a few prospective trials where they have said that patients who underwent surgery early had better results whenever there was a neurological deficit. So the current feeling is that most of the patients undergo a surgery for clearance of the disease, for release of the compression, and also to cure instability by spinal stabilization whenever you are having a patient with neurological deficit. So here you can see that this patient has got a compression over here. You can see that the cord is undergoing a lot of stretching over here. What you need to do is to completely remove the internal gibbous. You have to correct the kyphosis, and then you have to stabilize it, and also do an anterior column reconstruction by putting a cage over here. So when you decide to operate, what are the current topics and what are the current concepts in surgery? The concepts regarding surgery have undergone a lot of changes too. Now, as I mentioned before, even if you operate, all of you have to realize that the most important part that gives you success is not surgery, but actually it is chemotherapy that makes surgery very safe. So you should not do the mistake of not giving adequate chemotherapy whenever you're operating. Before chemotherapy, people were very worried to actually go near the site of focus. So you had the Albee and Hibbs methods by which there was a posterior fusion. But after the Hong Kong group started the surgery, they brought in the philosophy which held true for many decades, that TB is an anterior pathology and so much must be approached anteriorly. Now, this is Hodgson and Stock, who actually described the various approaches right from cervical spine to the lumbosacral junction. And this surgery is actually called modified Hong Kong surgery, where the entire TB focus is completely removed and the deformity corrected, and the gap is filled with bone graft. Now, this could be a rib graft, or it could be a fibular graft, or it could be a iliac crest graft. And this was actually giving a very good relief. But the main problem with this surgery was, especially when you operate on a very sick patient, there was a mortality in 4%, and there was a major morbidity in another 18%. So this is because of the need that you had to open the thorax or the abdomen. And this was actually a big problem. The second problem was that these grafts, which were kept on the anterior column, did not do very well all the time, because they had the twin burden of performing the role of biological bridging over here, and they had to also perform the biomechanical strut burden. And frequently you found that this is also what we reported, that unfortunately when you keep long grafts and you do not protect it by a spinal stabilization, the incidence of graft failure either by a slip or break was almost in 50%. And it was as high as 85% when the length of the graft exceeded 2 spaces. Now, when the MRC trials took place, it was a taboo to use instrumentation, because we thought that instruments cannot be used in a place of active spinal tuberculosis. But it is to the credit of Oga et al., who really proved that TB bacilli were slowly dividing, sessile form, and had little bioadhesive proteins, and they do not form a biofilm like pyogenic organisms. And in fact, if you use titanium implants, it was very, very safe to be used even in active spinal tuberculosis. So the second thought process was, you not only did the modified Hong Kong surgery, as has been done in this patient, you can see an anterior strut gap, but this graft and the healing was also protected by a posterior column. Now, this was actually good, but we went on to the next stage of surgical approaches, where we found it is also safe that whenever you had to replace and support a long defect in the anterior column, it was even good in the acute stage to use titanium or cages, which was filled with bone grafts. But still, the mortality and morbidity of the anterior approaches was a big challenge. Because as you can see in this patient, the child is already dyspneic because of a large thoracic kyphosis. If you do a thoracotomy approach in this patient, the patient is going to really die. The chances of mortality is very high. And in these patients with gross kyphosis, you can see that there is a lot of compromise on your thoracic cavity and lung volumes. And this picture is very typically called the bird's nest appearance. And doing a thoracotomy in these patients is really of very high mortality. And there are many papers which shows that the mortality rate is high and the complication rate is up to 31%. And most of the time, the major complication was pulmonary. So we went on to the next stage of thought process of why don't we do everything from the back? So we go from the back, we remove the tuberculous forces, and then we do instrumentation and we cause a collapse. And you can see over here, this is the typical approach. So you decompress the spine and removing the facet, you have a very good approach to the anterior column. You do a thorough debridement, and the anterior column defect can be made good by placing a bone graft, or now frequently you use a cage which is filled with bone graft. Now, 95% of all our surgeries for spinal tuberculosis, whether it is acute or late, is only by the back. And that is why we now call the front door to the spine is actually through the back. Now you can see that this is what has been done in this patient, a very good result. Another patient, you can see a complete destruction of L1 vertebra, and you can see that it has been very nicely compensated and reconstructed by a surgery all done from the back. Now, one of the things that you have to be very careful in spinal tuberculosis is you have to understand that there is a selective loss. This is ankylosing spondylitis, but here there is no loss of the anterior column. So a PSO is okay for here. But in spinal tuberculosis, the small fusion mass actually represents 3 to 4 vertebral bodies. And so when you actually correct the column, you need to be very careful that when you lengthen the column, you will find that you so much distract the anterior column that you cause neurological deficit. Alternatively, if you do a wedge osteotomy and you close the osteotomy from behind, then you cause a kinking or a herniation of the spinal cord. So you not only should do an osteotomy, but what you really need to do is you should avoid a shortening, acute shortening of the spinal cord, which can result in a kinking of the anterior spinal artery. So you just don't do a posterior closing, but also you have to do a anterior opening over here so that the spinal cord is kept intact. So this is called the posterior closing, anterior opening osteotomy, which gives excellent results. So you can see here, there is a very gross kyphosis over here. And in this patient, almost a still grosser kyphosis. And you have to be really careful in these patients when you position them, because you have to avoid hyperextension of the cervical spine, and you have to protect the eyes and the lips. And this is very important. And you do a big opening. You can do a double costotransversectomy approach over here. And then you remove this mass of wedge of bone over here. This is the spinal cord. You can see here. You remove the wedge over here by actually using a burr. You can see a mass of the cartilage tissue on the anterior side, which you remove. And once you remove that, you can see that the 2 columns of the vertebral columns are completely mobile. And once you get that, you can actually go and place a cage over there, and then you can slowly collapse. Now, this is very important. You can see a very gross kyphosis where the anterior column, a wedge osteotomy has been done. And in these patients, you can then slowly close. Now, when you do these osteotomies, it is very, very important that the anterior column is completely reconstructed. If you do not reconstruct the anterior column very strongly, you will find that there is an implant breakage, and that can cause a neurological deficit also. So you can see here that the anterior column is being reconstructed by a titanium cage filled with bone grafts, and then you slowly correct the kyphosis and you shorten the posterior column, and you can see a very good correction from here to over here. So this is very important. Now there are many good, we reported this in spinal tuberculosis in the European Spine Journal, and you can see a lot of patients who have excellent result by this. So the current concept is that the front door to the spine is through the back, because 95 or more percent of surgeries of the spinal tuberculosis can be done successfully. So it's many years, many decades since Sir Percival Pott described spinal tuberculosis. So where are we now? So we have got excellent surgical techniques and good chemotherapy, which gives good results. And so we have a high rate of success in individual cases. You can see in this patient, there is a tuberculous focus of the odontoid. It's a very difficult surgical technique, but with the help of computer navigation, we can accurately place screws and actually cure the spine. That is possible in individual cases, but we still have a lot to understand about the disease. Now, we don't know why some of the people have a lot of pain, why some people come with massive destruction of the spine with no pain at all, why there is a lot of compression on the cord and some patients don't have any neurological deficit, whereas some patients have a lot of neurological deficit. Why do some patients have a huge abscess, and why in some patients it is dry without a big abscess? So you can see here, this patient has litters of pus on the psoas, on the posterior side, everywhere. But some patients have no pus at all. You can see 3 litters were completely missing. The most important thing is, while we are having a lot of advance in surgical techniques, our success in controlling the disease on a national scale has been not so successful. That's very unfortunate. And so many patients end up with these massive problems at all. Our current major problem is multi-drug resistant and extensively resistant tuberculosis. That's a separate topic. And you need to be sure that in the present state, where there is a lot of controversy on the exact incidence of multi-drug resistant tuberculosis, but there are a lot of reports from North India which says that it can be more than 15 to 28%. Now that's very worrying. That means that every single case you suspect to be tuberculosis has to be biopsied, has to have a histopathological confirmation and a gene expert. And before you start the drug therapy, you need to know whether there is a resistance in these patients, because you may lose a lot of valuable time by a few months by missing drug resistance. So you need to always have a gene expert study in these patients. We also need to look at HIV and TB, which is more than double trouble for these patients, and there is a lot of problem. So the crux of the matter is the conquest of tuberculosis cannot be achieved by vaccination or immunization. The success that we had with smallpox or the success that we had with polio by immunization cannot be achieved by tuberculosis, because it has to happen only by improvement in socioeconomic conditions and nutrition, and that looks like a big problem. So temporarily we looked better than the drug, but slowly the drug has become better than us. And so just like we looked at goodbye polio, I think we need to look at all the socioeconomic, nutritional, hygiene, and the distancing factors which will make us a country which is free of tuberculosis of the spine and actually tuberculosis of any part of the body. So I'd like to thank the Indian Orthopedic Association and the PACE PG Academy for continuous excellence, and especially Janssen India and Insignia for giving us this opportunity. And thank you very much.